Welcome to Omnicurus Originals and the Diabetes Awareness Series. Today we have Dr. Y. Sadasiva Rao with us. Dr. Rao is the Honorary Secretary of RSSDA Andhra Pradesh chapter. He is one of the finest diabetologists of Andhra Pradesh with a long-standing experience of practicing diabetology in India. He was recently honored with the National Award from National Conclave on Diabetes and Diabetic Food at Mumbai for the efforts and contributions on diabetic food treatment. Dr. Rao was honored for treating about 10,000 patients without amputating their legs who were suffering from diabetic foot problem. Welcome, Dr. Rao. The stage is all yours. You may please begin.
And also, I would like to thank Omnicurus for giving this opportunity, and I welcome all the delegates who have logged in. And today I will be talking on CGMS. Is it an invaluable tool or waste of money? So, before we know why it's an invaluable tool, we should know that the monitoring systems in diabetes are changing. So we are coming out from an era of A1C to an era of TIR. So we'll discuss about that in the early 10 minutes, and later on we'll go on to know what is continuous glucose monitoring and what are the benefits and burden. And later on, lastly, we'll be talking about the ambulatory glucose profiling, and I'll end with that. So I'll start here. We'll go to the era of A1C and its limitations. So what does A1C mean to the patient? So it's the main glycemic metric for guiding therapy changes, and it's also the metric for rating the quality of diabetes care and medications. So what does it mean to the physicians? We use it as the main diagnostic criteria, and it's the standard marker to assess risk of complications. So we target standard used in diabetes algorithms to modify therapy and set up new clinical trials. So what does it mean to the regulators? So the main outcome marker, it's the main outcome marker for health authorities' approval of new glucose-lowering medications and technologies for diabetes management. Coming to the limitations of A1C, it does not capture hypoglycemia. So people with diabetes whose A1C levels were less than 7% spent more than 90 minutes per day with mean glucose levels less than 70 milligrams per deciliter. So in the impact study, participants with similarly well-controlled diabetes spent more than 200 minutes per day with mean blood glucose levels below 70 milligrams at baseline. It also does not capture individual differences in A1C. So varying patterns of glycemic control with identical A1C levels and similar mean glucose concentration, and also some of the conditions can have a detrimental effect on the value of the A1C, that is like anemia, hemoglobinopathies, iron deficiency, and pregnancy. So next is, it does not capture glycemic variability. Studies have shown association of glycemic variability with increased risk of hypoglycemia, cardiovascular outcomes, and all-cause mortality. See this slide, wherein there are two case scenarios, wherein the patient 1 and B both had similar A1Cs, but the difference is in the patient 1, there is a high glucose variability with episodes of hypo and hyper. You can see it clearly. And the patient 2, low glucose variability is there, and there are no hypos or hyperglycemic episodes. And of the two, which is more problematic is the patient number 1, because he can land in, because high glycemic variability, he can land in cardiovascular mortality and morbidity. Increasing fasting glycemic variability is correlated with adverse outcomes as per the DEVOTE trial. It has shown that the high variability causes increase in all-cause mortality and the 3-point MACE, and also it can also cause severe hypoglycemia when compared to the low variability. One thing, we are all used to the SMBG. We tell our patients to monitor this blood glucose levels at a particular time. So we usually use 3-point profile or 4-point profiles or 6 or 7-point profiles when we tell the patient. So as soon as he gets up, we ask him to measure his blood glucose in the fasting state, before lunch and before dinner, and sometimes at bedtime. And in rare cases, we also tell them to monitor blood glucose at 3 a.m. in the morning. So see, the CGM shows glucose levels and trends more clearly than the SMBG. you can see here clearly, because the patient not to get up and not to worry and not to prick himself. So if he's put on a glucose monitoring system, he can happily relax, and the blood glucose goes on monitoring itself with the sensor. Yeah, we'll know about in the later slides. So it can detect hypo as well as hyper. You can see the patient going into hypo before lunch and hyper before dinner, and after bedtime is going again into hypo. So all these things can be clearly seen with the CGM. One thing is, the world is changing, so the way we practice is also changing with the COVID pandemic. And so we also learned that how to practice with the telemedicine, and also we are now conducting all the most of the meetings through virtual. And actually, RSDA had really done a wonderful thing in doing a virtual program for 4 days. It was a grand success. So now we have to shift from A1C to time in range. So you can see here the international consensus meeting conducted in 2019 in Berlin has come out with the consensus on time in range, but the advanced technology treatment for diabetes group has suggested that. And so different countries are moving at different rates with regard to implementing these changes regarding time in range. So what is time in range? We'll know about it. Before that, what is continuous glucose monitoring system, or what is continuous glucose monitoring? So CGM is based on a device that provides 24-hour real-time glucose levels. You can see the rate of change of glucose variability, and alerts and alarms for actual or impending hypo and hyperglycemia. Systems are becoming more accurate, smaller, more user-friendly, and be combined with continuous subcutaneous insulin infusions to provide a sensor-augmented pump called SAP. So, however, user input is needed. Fully automated closed-loop systems are in development that will require no user input. So, once you have a sensor where you implant the sensor in the subcutaneous tissue, mostly in the abdomen or in the upper arm, and you have a CGM receiver, or you can it can also be wherein you can view the what are all the values in that. So it can be also called as a reader, CGM receiver or reader. So usually these readings from the USB are transferred through Bluetooth, and so thereby you can see the values and they are interpreted. In the next slides I'll show you. So what are the indications? CGMS has been used as an educational tool to document the incidence and magnitude of hypoglycemia in adults and children with diabetes, pregnant women, patients after transplant, children with glycogen storage disease, gastroparesis, cystic fibrosis, celiac disease. And what are the common clinical situations that we use CGMS? So situations that require detailed information about blood glucose fluctuations, like in GDM and type 1 diabetes or diabetes in children, in ICUs, and also we use it actually routinely in our indoor for our patients who are admitted in order to prevent 4 or 5 times blood pricks and all these things, and to diagnose and preventing hypoglycemia, especially nocturnal hypoglycemia, and to diagnose and preventing postprandial hyperglycemia, and also to adjust the therapies to improve control. We use CGMS. So you can see the evolution of the CGM. What's the benefit of technology? So earlier CGMs they were bulky, and actually they were not for private use. Actually, they are intended only for clinical use, and they were very costly also, because around 1 lakh. I spent a lot of money on that, and I used it only on a couple of occasions, wherein it is attached to the sensor is implanted on the abdomen, and then there is also again a reader on that, and it's weighed about almost 1.2 kgs. The second generation were all miniaturized and they were better accurate. Then you had the third generation, wireless connectivity, subcutaneous sensor is a patch. There was a patch was there. Then we had the emergence of the flash glucose monitoring class of CGMS. Then fourth generation were implantable sensors. They were implantable with where they can act for about 3 or 6 or 12 months in use time. And because earlier ones, actually, you had to change the sensor every 3 days. And now you have sensors wherein they act for about 7 to 14 days. And now newer sensors, the fourth generation, actually can be used for 3, 6 or 12 months. The fifth generation, the band-like CGMS, small CGMS the size of a coin, non-invasive monitoring, small contact lens. It can be used for a single use or disposed and for intimate use. So even like a contact lens also, we are now having CGMS, though they're not available in the country. And you have the Dexcom, which is very costly. You have the Abbott, the Freestyle, already most of us are using it, the Libra and the iPro. Coming to the CGM, how does it operate? See, you have a glucose sensor which is inserted into the abdominal subcutaneous tissue or into the upper arm, and it converts the measured interstitial glucose levels into an electric current via an electroinsumatic 3 electrode cells in which a constant potential is maintained between the working electrode and reference electrode. The principle is based on the generation of hydrogen peroxide from glucose and oxygen via the enzyme glucose oxidase. It continuously measures the glucose concentration of the interstitial fluid every 10 seconds, then stores an average glucose value for each 5 minutes period for a total of up to 288 measurements each day. So it is designed to provide continuous glucose measurements in the range of 40 to 400. So these sensors act anywhere from 3 days to 14 days. And also now I should told you the latest generation of sensors can act in up to 3 to 6 months. And in future, maybe they may act in for 1 year as the technology develops. So how does the sensor measure glucose? The platinum electrode coated with glucose oxidase and covered with a semi-permeable membrane. The sensor is inserted into the skin, is bathed in interstitial fluid, and measurements are made every 10 seconds for up to 72 hours. That is with the initial sensors. Now they're measured up to even 14 days. Yes. So you can see this is how the sensor measures the glucose values. Now coming to the International Consensus Report on CGM and time in range. So the report provides guidelines and recommendations for clinicians, researchers, and people with diabetes to use, interpret, and make decisions based on CGM data for effective diabetes management. It also supplements previously agreed upon CGM metrics. So the first recommendation was made by an expert panel on the standards of CGM metrics in 2012. In 2017, various publications of CGM metrics and CGM data evaluation, but no formal adoption by the professional organization and application in clinical practice was done. In 2019, the international consensus at the Advanced Technologies and Treatment for Diabetes developed CGM targets based on currently agreed upon the CGM metrics. So the recent guidelines updates towards the standardized CGM metrics and reporting. 10 CGM metrics for clinical care. So guidance on targets for TIR, time in range, TBR, time below range, and TAR is time above range for adults with type 1 diabetes, type 2 diabetes, and special populations, including older and high-risk individuals and during pregnancy. So standardized ambulatory glucose profile, that's the AGP, as a template for data presentation and visualization can be had. So now we see the difference between A1C and TAR. Coming to the A1C, it evaluates single A1C values, which compares every 3 months, whereas TAR evaluates continuous glucose levels, and it can be compared at any time period. How many, if you want it from morning 6 to 6, you can have that time period for 3 days, for 7 days, or even 14 days, and or even longer. So the A1C does not capture hypoglycemic or hypoglycemic levels occurring in the same day, whereas TIR captures, the CGMS captures all glucose levels for the given time frame and identifies time within a safe range. So A1C, the immediate effect of therapy change not recorded, whereas you can immediately detect the acute effects of therapy change. So when you see with the values in this CGMS, whether they are not in the time in range, certainly we can make immediate effects in the therapy. So A1C has a bad correlation to patient-reported outcomes, whereas TIR has a good correlation to patient-reported outcomes. So there is also high susceptibility to interference with the A1C values, like anemias or even age can interfere, and also various laboratories are there wherein they don't use a standardized methodology in our country. And whereas TAR has a low susceptibility to interference. Whereas coming to the long-term studies, there's a good correlation to clinical endpoint, and many long-term studies are available with A1C. Whereas there's a correlation to endpoints are unclear. Hardly any long-term studies are there for TIR. So now coming to the correlation between A1C and time in range in type 1 and type 2 diabetes. So there's a good correlation between A1C and time in range across a broad range of subjects, whether in type 1 diabetes and type 2 diabetes, ages and technologies across 18 studies. So for every obsolete 10% change in percentage TAR, there was almost 0.8% reduction in A1C. So if you can see here, when the time in range is around 0%, that means A1Cs are about 12.1%. And so when you had a time in range about 100, that means A1C is 4.3%. So when the A1C is around 70%, the A1C is around 6.7%. That means there's a good correlation to A1C and blood sugars. So coming to the studies, the TIR and macrovascular complications. So for each 10% less time in range, retinopathy progression increased by 64% and microalveolar outcome by 40%. So this is a 10-year cumulative incidence of developing diabetes-related complications after improving time in range. So whether it be myocardial infarction, end-stage renal disease, severe vision loss, amputation in type 1 or type 2, you can clearly see that when the patient's time in range was increased from 58% to 70 or 80, there is a significant improvement in the complications or reduction in the complications. Now we'll see the benefits of continuous glucose monitoring or burden. What are the benefits of CGM versus these self-monitoring for plasma glucose? CGM can improve glycemic control, can reduce the risk of hypoglycemic events, particularly in high-risk individuals, and it enables visualization of glucose patterns throughout the day, including changes following meals, exercise, medications, and in response to changes in treatment regimens. And also, it also allows evaluation of glycemic variability within and between the days. I mean, intra-day and inter-day variabilities also can be evaluated with CGMs. And it can be used effectively with multiple doses of insulin therapy or subcutaneous insulin infusion. So advances have made CGM more convenient and accurate. Current CGM devices provide a minimally invasive method to measure real-time interstitial fluid glucose every 1 to 5 minutes. Subcutaneous needle-type electrode detects enzyme catalyzed oxidation of glucose into hydrogen peroxide, as has already been stated. The accuracy of the latest devices has improved towards a MAD of less than 10%. That is the mean value of individual absolute relative deviation. So this can potentially allow treatment decisions to be made based on CGM data, that is an insulin dosing claim. So barriers. Certainly any good thing also has barriers. Like insulin usage, we also have faced so many barriers in our treatment. The need to continue to measure self-monitoring of plasma glucose before taking action is a regulatory requirement. Measurements obtained with CGM systems may differ from those of the self-monitoring blood glucose systems because they are from the interstitial fluid. And the need, we have to educate the patients and providers in the use of these CGM devices. And there can be calibration issues, accuracy and precision issues, and sensor lifetime is also very important. And there's always a physician and clinical inertia in the usage of the CGMs. And another thing is high cost reported by the parents and the patients, frequent annoyance from alarms, and also some patients complain of insertion pain and body image issues related to wearing. Some people may not like to have something on their body. They feel that it's like, that interferes with their personality. So they don't like it. Next is interruption to daily life. So these are some of the barriers of CGM usage. But when you look into clinical usage, summarizing this, A1C and the TIR, the A1C is the gold standard for diabetes management, and however, it does not demonstrate a holistic and individualized glucose profile. CGM provides a closer view of the person's glycemic status and aids in better glycemic control. Increasing TAR has been shown to have associations with reducing micro and macrovascular complications in people with diabetes. The international guidelines have now been updated to include consensus on CGM data interpretation. The latest ADA book also has come out on that guideline. A need to exist to move beyond A1C alone and also consider CGM data for optimal diabetes management. Now, we'll also, nothing about CGMS is totally over unless we talk about the ambulatory glucose profile. Now we have everything ambulatory. We have the ambulatory blood pressure measurement machines. Now we have the Holter monitor. Now glucose is coming. We are talking about the ambulatory glucose profiling with the CGMS. Yeah. So I will talk about the rationale of ambulatory glucose profiling, then interpreting of the AGP graph, the benefits to healthcare providers and patients. And before going on to summary, I have a few case presentations from my clinic where I will be talking about the 14th day AGP. Yeah. So the rationale for AGP is the goal of diabetes management is to control glucose levels to reduce the risk of serious and short and long-term complications. To achieve this goal, patients and their healthcare providers need to monitor glucose levels regularly. SMBG and A1C may not provide a complete picture of the changes in patients' glucose values. That's because they don't account for all glycemic variability. So glycemic variability is described as the amount of a patient's glucose levels vary over time. So the key benefits of the 14-day AGP graph, which I'll show you in the next few slides. Why measure glucose variability with AGP? The glucose variability, in addition to A1C result, may be a more reliable indicator of glycemic control than A1C alone, and the AGP goes beyond A1C by revealing hypoglycemia, hyperglycemia, and glucose variability. The most important identifying aspect of the AGP is that it reveals glucose variability, postprandial glucose excursions, and hypoglycemic trends. The high glucose variability can lead to increased risk for hypoglycemia. This is because the efforts to control the highs can result in a dangerous lows at the other side of the range. AGP reveals glucose variability by two measures. The distance between the 10th and the 90th percentile curves shows how widely glucose readings have varied at that time of the day. A median curve that rises and falls shows glucose instability across the day. So here are the case studies. Yeah, you can see on the first day wherein the patient had 0% time in range and 100% was time above range. And as we can see, every day we are monitoring the patient and we are changing the therapy, and we're also actually closely monitoring what nutrition they're taking, or as advised by our dietitian, they're following it not, or everything we have been changing every day. You can see how the time in above range target was coming down. 100 it has come, then it has come to 97% on the 5th day, and subsequently by the 7th day it has come to almost 33%. And slowly the time in range was going up. And on the 14th day, you had almost 0% time above target, 0% below target, and 100% time in range were achieved with the CGMS. So we can see clearly the effect of our therapy on the patient, how the patient is following. This patient actually, I couldn't control her, and her A1Cs were almost high for the past 1 year. Then I said, please use this new tool that we are having. It tells us a lot, and we'll be benefited by it. So that every day we went on changing the therapy because they are from nearby place and they are not very distant from our center. And so, or if the person is 1 hour away from center, we used to ask them to come every 2 days to see the readings and then change the therapy. Next patient you can see here. This patient had 93% time about target and only 7% was the time in range. And right from the 5th day onwards, you can see the time in range improved. 52% has come there, and by 7th day it has come to 65%, and time above target was only 35%. By the 13th day, the patient had almost 0% time about target and 96% was achieved. Time and target was achieved at 96%. And even at 14th day, you had 95% time and target and 5% time below target. So sometimes, yes, when we are trying to closely monitor the patient, sometimes the patient can go into unnoticed or asymptomatic hypoglycemia can be present. That can be detected with the CGM systems. And here, the 14th day, almost there were no above or below targets. With only 1% below target was there. So certainly we can evaluate, we can see how a therapy is efficacious or not, how each drug is acting on this patient, and thereby. So the summary of this AGP was CGM provides more data than SNBG and making it easier to build comprehensive AGP graphs which can provide more information about glucose variability, hypo and hyperglycemia, that what I already have showed you. And AGP is a visual report that collapses all glucose readings as if they have occurred in a 24-hour period, making it easier to visualize glycemic patterns. The AGP graph provides a visual representation of glycemic targets, glucose variability, patterns of hypo and hyperglycemia. The AGP graph provides the information that healthcare providers need to assess and fine-tune therapy. The AGP graph is a valuable tool that may enhance the communication and partnership between healthcare providers and their patients. Thank you.